So this patient came to see us in the office, had a visiting nurse that was changing his catheter. She'd see this patient every 4 weeks and typically wouldn't have any issues with him. He was an older gentleman that finds it very hard to get it himself as well as his family to the offices to have the catheter changed. In this case, the catheter was changed and the nurse had some difficulty. He experienced some bleeding, some discomfort and pain, and ended up in the emergency room at an outside hospital. Once he was in the ER, they found out that he was pretty sick. He had an elevated white count, he was starting to have fevers, his catheter wasn't draining. At the time, his urinalysis showed that he had a very bad infection. He had high pus cells in his urine as well as bacteria. They empirically started him on broad-spectrum IV antibiotics, and after a few days, they looked for the urine culture results to tailor his antibiotics. And unfortunately, it came back mixed organisms. They didn't reculture him, and at that point, they were left with continuing IV antibiotics for him to go home on. All in all, he was in the hospital for 3 days, and he had seen me in my office after he left the hospital. At that point, we ran a guidance, and luckily we were still able to identify the 3 organisms that were contributing to his infection and found an oral alternative instead of keeping him on the IV broad-spectrum antibiotics. And this is a case where we see quite often where patients end up in the ER or other facilities and are diagnosed with what we clearly see as an infection, but urine culture, because of its flaws, isn't able to identify the bacteria that's actually causing the issues for this particular patient. We're over-treating and overexposing them to broad-spectrum antibiotics because of the issues that we find with urine culture and sensitivities. And in this gentleman's case, if he ended up in our office beforehand, then we would have been able to identify the bacteria, and instead of exposing him to a PICC line, IV antibiotics, 3 days in the hospital, he could have been in and out of our office with an oral antibiotic. In the situation that I had seen with my particular patient, guidance was very useful in getting him off the IV antibiotics and to an oral antibiotic. The antibiotic stewardship, I think, is the most important thing in this situation that we want to be aware of as we see patients with complex urinary tract infections as well as recurrent urinary tract infections, so we can prevent resistance with some of the more stronger antibiotics that we have available. In this case, this patient was on IV antibiotics for at least 4 to 5 days, which could have been avoided if we had guidance available and used right at the onset of his infection. He could have been identified within 24 hours and could have avoided a long hospital stay, IV antibiotics, PICC line, as well as complications in the elderly with infections can be much more serious than in more healthier patient populations. In this case, it could have caused more serious complications for him. It didn't take long for me to appreciate the benefits of guidance. We in the beginning had patients with urinalyses and cultures that showed an infection, but the patient's infection wasn't clearly identified on the culture results. And with guidance, we were able to tease out which bacteria was the culprit as well as the proper antibiotic to treat them. And after only a few cases of patients who have been in and out of various emergency rooms or offices where we couldn't pinpoint what the cause was for their symptoms, guidance was able to do that in a fast turnaround time, as well as clearly showing us which antibiotic is the best for their particular bacteria. There currently are many tests that are available to use PCR to identify which bacteria are causing a patient's urinary tract infection. Not all tests are the same. The benefit of using guidance not only is the timely manner that the bacteria is identified, but more importantly, the pooled sensitivities where we're able to find out which antibiotic would be the best, or one of the antibiotics that could be the best to help manage this patient. Some tests rely solely on genotype and not phenotype when it comes to sensitivity results. And all of us know that you can't rely mainly on genotype when you're managing some of these patients, but need specific sensitivities that are tailored or at least used for that particular patient and their infection.